We'll move on to our next speaker, who is Dr. Whitney Jackson. She is an assistant professor of medicine and transplant hepatologist at University of Colorado, where she's also the medical director of our living donor liver transplant program, one of the largest in the United States. Today, she'll be sharing when to refer patients for liver transplant evaluation. Dr. Jackson?
Hi, good morning. Thank you to the course directors for inviting me to speak today on transplant updates, when to refer for liver transplantation. Our objectives, are to review the indications for liver transplantation, review organ allocation and why we consider living donor liver transplantation in all of our patients, and to review our approach to alcoholic hepatitis. There are many indications for liver transplantation, but hepatocellular carcinoma, alcohol-associated liver disease, and non-alcoholic fatty liver disease are the most common reasons people need a transplant. And so with our limited time today, we'll focus on these. Effective therapies for hepatitis C have transformed our landscape of chronic liver disease in the United States. Alcohol-associated liver disease and NAFLD have emerged as significant clinical and economic healthcare burdens. The lack of effective strategies and therapies for these contribute to increased disease severity and lead to end-stage liver disease requiring transplantation. The MELD score predicts 3-month mortality in patients with liver disease. Sodium was integrated into MELD in 2016, and it was also shown to be an independent predictor of mortality in your cirrhotic patients. You can see that a MELD of 26 carries a 20% 3-month mortality, while a MELD of 40 is associated with a 90 3-month mortality. Traditionally, a MELD of 15 or higher was an indication for transplant. This is where there was an intersection between survival benefit of keeping the current liver versus a transplant. However, modeling was during the hepatitis C era, and post-transplant hepatitis C recurrence was likely to be affecting post-transplant outcomes. So while MELD remains predictive of mortality, its accuracy has decreased since 2002 as the prevalence of hepatitis C has decreased, especially when we look at the fatty liver and alcohol populations. You can see here that fatty liver and alcohol have the lowest C statistic compared to hepatitis C. More so when we recreate that prior graph, but separate the hepatitis C patients from the alcohol population, we see that patients with alcohol-associated liver disease may derive benefit from transplant at lower MELD scores than the hepatitis C population. So is there a strict MELD cutoff for transplant? Probably not. MELD probably isn't always enough. One example is in cirrhotics with ascites or significant portal hypertension. For the same MELD score, 90-day mortality is higher in patients with moderate ascites as compared to no or small ascites. A patient with moderate ascites and a MELD of 11 has equivalent risk of death as a patient with no or small ascites and a MELD of 16. You can essentially add 4 to 5 points for these patients. We also know that sarcopenia is associated with mortality and that women are disproportionately affected. A new MELD 3.0 may be proposed to more accurately reflect that petite women are disadvantaged on the wait list. It would incorporate female sex, albumin, and create a lower ceiling for creatinine. Now, in patients who cannot have their liver cancer cured with resection, liver transplant is their only other potential curative option. Large tumors were found to recur and limit post-transplant survival, but when transplant is restricted to early HCC, a 4-year survival rate of 75% can be achieved. This was first demonstrated with the Milan criteria, a single lesion less than 5 centimeters or 3 or fewer lesions each 3 centimeters or less. Later, UCSF was able to demonstrate similar outcomes with extended criteria up to a single lesion that is 6.5 centimeters or less, or 3 or fewer lesions, 4.5 centimeters or less, adding up to a total diameter of 8 centimeters or less. In most cases, patient selection criteria are based on radiologic imaging performed to assess the extent of intrahepatic disease that's present and to exclude extrahepatic spread. However, it's worth noting that imaging studies have been shown to underestimate tumor stage in 20 to 30% of cases. It's also possible to treat your patients with local regional therapy to downstage them to within Milan. If that's able to occur and the patient remains well treated with an AFP level that's less than 500, then it's possible to be listed for transplant as well. Once your patient is determined to be within Milan or downstage to Milan, they can be listed. And after a period of 6-month wait, they may gain MELD exception points. Exception points have changed over time, and that they're now based on the median MELD score at time of transplant at the hospital. So in Colorado, our median MELD at time of transplant over the past 3 months has been 30. And so these HCC patients are granted 27 points. To summarize, an exact MELD cutoff to refer for transplant probably doesn't exist currently. I would refer at a MELD of 12 or any MELD with decompensation events and HCC that's within UCSF criteria so that we can work to downstage them. Also, sarcopenia, especially in women, is a sign that they are quote unquote sicker than their MELD score and would benefit from transplant. Traditionally, we've existed within transplant in a high MELD world where our patients had to be competitive for an organ. And the weight at even a high MELD score of 38 could have great geographic variability. In 2020, UNO started to draw circles around donor hospitals and offer organs based on urgency and proximity to the hospital. Hence, candidates with a higher medical urgency had broader access to organ offers before less urgent candidates who were closer to the donor hospital. And despite an increasing number of transplants in our country, the waitlist continues to reflect a limited resource. You see this gap between our waitlist additions, the people that we think need a transplant, and the actual transplants that are occurring. And this is exactly why we offer living donor liver transplant to our candidates on the waitlist. Living donor liver transplant is when a recipient's organ, the recipient candidate's organ, is completely removed and a healthy lobe or piece of liver from a healthy donor is put in its place. That remnant liver in the donor and the piece of healthy liver in the recipient both grow to the full size of an organ. And we know that the worst place to be is on the wait list, regardless of if you're a high MELD or a lower MELD candidate who we think needs a transplant. You can see here, these two black lines show patients that are sitting on the wait list and their chance of death, whereas a living donor liver transplant that was received to a higher MELD patient or a lower MELD patient. So the benefit, the survival benefit of living donor liver transplant, even in the MELD era with these lower MELD patients, is really evident. Long-term outcomes are equivalent, if not improved, in living donor liver transplant compared to deceased. And living donor liver transplant provides access to an organ for all candidates in need of transplant, regardless of MELD score. You can see here the trend in the United States is that more living donor liver transplants are occurring in lower MELD patients who may have limited access to a deceased organ. And just to note, the University of Colorado is one of few high volume centers for living donor liver transplant in the country. So access to living donor liver transplant is increasingly recognized as being limited depending on your geography as well. And just to note some of our donor outcomes and motivations, all of our donors are back to their normal level of activity after donation. All donors say that if given the chance to donate again, they would want to do it. And some of the things that they've said are that we're a community and we have to take care of each other, and they're donating because they value life and they know that people are in need and no one deserves to die. The advantages: allocation is based on MELD sodium to guide utilization of a limited organ supply. We work within an imperfect system of increasing complexity when it comes to allocation and distribution of organs. Living donor liver transplant frees the recipient from the allocation system and the wait list. It increases the donor pool overall. You have the ability to get transplanted before you're critically ill with improved recovery, and you have equivalent survival. Now, something that I want to do today is just touch on our center's approach to alcohol, because it's really changing over time, as it is really changing nationally. Now, this is projection of the incidence of alcohol use disorder in the future, and it's under a theoretical model where it would either be under status quo, the trends that we're seeing now, if there was a theoretical moderate intervention to decrease the incidence of alcohol use disorder, or a strong intervention. And you can see, and I'm sure that everyone is experiencing, that we are just surrounded by alcohol use disorder and its influence on the liver. The change to our approach to alcohol is not only driven by the increase of alcohol use disorder, but also that there are small studies of highly selected patients that have been transplanted for alcoholic hepatitis, and that their outcomes in small studies in carefully selected patients tend to be equivalent to those of patients with alcoholic cirrhosis. On the left, you can see patient survival after transplant over time. Just note these small numbers. And on the right, you can see alcohol relapse after transplant. And there's really no difference in people who have had alcoholic hepatitis versus alcoholic cirrhosis. So this evolving background is not only is the incidence of alcohol use disorder rising, not only have small studies of carefully selected patients for transplant shown promising results, but also a period of 6-month abstinence, which is we've all heard of the 6-month rule. It really does not predict future sobriety. These mandatory sobriety times probably are encouraging dishonesty amongst our patients. And some patients have high mortality within the 6-month period, and we're probably not able to help them because we don't see them early enough. This really just emphasizes this COVID effect. This is the percent change from baseline of transplants that are either people that are being listed as candidates for transplant for alcoholic hepatitis, or liver transplants that are occurring for alcoholic hepatitis since COVID, this first state level shelter in place order that occurred. And it's up really 400%, which is really notable. So who do we consider for transplantation with alcoholic hepatitis? These are people who are medically refractory. So if they've been started on steroids and we have not seen a response after steroid treatment, these candidates must admit to significant alcohol use. People who are denying alcohol use either don't have alcoholic hepatitis or are just in denial about their underlying alcohol use disorder. And the patient has to be healthy enough and engaged enough to engage in our transplant process, which would mean that we want to see evidence of counseling or rehabilitation prior to transplant, or if they're too sick, then have them committed to it immediately after with a clear plan. And in order to engage with the psychosocial team, they have to have a normal mental status still and not be so sick that they're on dialysis and not able to engage in the process. There are a lot of attempts to stratify out the people who are lower versus higher risk of alcohol use after transplant. And so this is something that our program is trying to integrate into our protocol at this point. And these carefully selected patients, the things that we will really consider as a multidisciplinary team will be protective factors against recurrent alcohol use and negative factors that might predict it. So people with coexisting psychiatric disorders, personality disorders, they are people that would be higher risk of alcohol relapse in the future. Family history of alcoholism, repeated attempts at rehabilitation that are unsuccessful, ongoing substance abuse despite clear physical and social consequences, and social isolation. Protective factors tend to be people who have a very strong support system, are able to engage in other activities that are meaningful to them, and who develop a lot of hope and self-esteem for going forward in the future. And they also have to perceive the negative consequences of their alcohol use. So referral considerations in this case, there is no 6-month rule. Patients need to demonstrate insight and commitment to abstinence. People can't be too sick where they cannot engage with the psychosocial team. So overall today, I just want to conclude by saying, please refer early, that living donor liver transplantation is something offered to every candidate that can free these patients from the wait list with excellent outcomes, and the role of transplant for alcoholic hepatitis continues to evolve. And this is my information and contact information for our program.
Excellent. Thank you, Dr. Jackson. That was a wonderful talk. I think that brings up lots of discussion points, so I'm looking forward to discussing those in our upcoming panel discussion. And if you could unshare your screen, please.